The topic I'm going to discuss today is Juvenile Idiopathic Arthritis. This is the second lecture of the series, and we are going to discuss investigation, differential diagnosis, and treatment in these cases. So first of all, systemic diagnosis and management should be performed by a physician familiar with the management of JIA, typically a pediatric rheumatologist in association with pediatric ophthalmologist. Anti-nuclear antibody positivity denotes an increased risk of uveitis. HLA-B27 testing is useful in differential diagnosis and if present may indicate an increased risk of uveitis. Rheumatoid factor is also useful in differential diagnosis. Then is the screening. There has been a shift in recommendation towards long-term 3 to 4 monthly review intervals in all high-risk categories. Review should continue in most cases until the age of 12 years. Initial examination within 6 weeks of the first diagnosis of JIA. Delayed early examination is an important cause of morbidity. Visual symptoms or a suspicion of ocular signs, synecdoche, cataract, band keratopathy should lead to urgent ophthalmological referral and slit lamp examination within a week. Initial 2 months review for 6 months may be considered for all newly diagnosed oligoarticular, psoriatic, polyarticular and enthesitis related patients regardless of ANA status, followed by 3 to 4 monthly intervals. Polyarticular every 3 to 4 months, but some guidelines reduce the interval to 6 monthly. After a number of years, high-risk factors that might be considered in deciding whether to alter the interval include the presence of ANA, onset of 7 years of age, and female gender. So these are very high-risk factors. Systemic onset and polyarticular RF positive patients, most authorities recommend at least an initial screening examination with some guidelines suggesting annual review. Missed appointments must be effectively detected and patients rebooked. Information for parents should include an emphasis on the importance of compliance with screening as well as the need to seek urgent advice should there be any cause for concern, such as visual symptoms, ocular redness or clouding, or abnormal pupils. Self-monitoring should be encouraged. At eventual discharge from screening, patients should be warned to self-monitor by checking the monocular vision at least once a week because the risk of uveitis has not entirely disappeared. By this age, they should also attend an optometrist annually for an eye examination. Selected patients, such as those with learning difficulties, require an ongoing ophthalmological screening. So they should be reviewed properly. Differential diagnosis in children include idiopathic, juvenile, chronic iridocyclitis, otherwise healthy patients with juvenile chronic anterior uveitis, other types of juvenile arthritis and uveitis including juvenile reactive arthritis, juvenile inflammatory bowel disease associated arthritis. Juvenile sarcoidosis is rare. Pulmonary involvement is less common than in adults, may be granulomatous and involves the posterior segment. Lyme disease usually presents with intermediate uveitis in conjunction with significant anterior uveitis. Intermediate uveitis, 20% of all cases of pediatric uveitis. Neonatal onset multisystem inflammatory disease is a rare idiopathic chronic relapsing disease that predominantly involves the skin, joints, and central nervous system. About 50% of children develop recurrent anterior uveitis. The absence of posterior synecdoche and no tendency to glaucoma and cataract formation are characteristic. Masquerade syndromes such as anterior segment involvement by retinoblastoma, uh, familial juvenile systemic granulomatosis, Blow syndrome is rare autosomal dominant disorder characterized by childhood onset of granulomatous disease of skin, eyes, panuveitis, and multifocal choroiditis, and and joints. Then comes the treatment part. The aim of treatment should be the suppression of all active inflammation. These children should be referred as soon as possible to a uveitis specialist. Topical steroids are initially effective in 80% of cases. Mediatic agents can be used to prevent synecdoche formation. A relatively short-acting preparation such as cyclopentolate should be prescribed and discontinued as early as possible, particularly in monocular treatment of younger children susceptible to the development of amblyopia. There is also a role of periocular steroids, oral steroids, and NSAIDs. Now, the most important part is systemic immunosuppressive agents. For example, methotrexate, infliximab, and adalimumab. They should be considered at an early stage as this has improved the overall visual prognosis in recent years. These children are usually under the management of a uveitis specialist, typically working in collaboration with the pediatric rheumatologist. Etanercept should be avoided as it can result in severe worsening of inflammation uh, in these cases. So, first line of treatment is steroid as in all cases of uveitis. Um, then there is treatment for complications like secondary glaucoma. If topical medication does not control the IOP, surgery may be needed. The long-term results of trabeculectomy with mitomycin C in children with JIA are are improved if they are using systemic anti-necrotic factor medication. Wearable implantation also result in good long-term IOP control, but is associated with a 5% risk of hypotony, maculopathy. Uh, Cataract extraction is often needed. Primary IOL implantation was a controversial issue in the past, but a low complication rate with good visual results has been recently reported. With this approach in children on immunomodulatory treatment, posterior capsular